Okay. Clock.
Okay.
So if you would like, I'll go ahead and welcome everyone. My name is Tim Armour with the New Mexico Kidney Foundation. We really appreciate all those who are participating and joining us in today's presentation about kidney health and the relationship with diabetes. So we do have a short presentation here that Dr. Barrantes, the president of our board of directors, will be giving, and then we'll follow that up with a question and answer session. If at any time you'd like to chat, feel free to post questions there, and we'll be watching that and responding to those at the end of the presentation. So with that, I will turn it over to you, Dr. Barrantes.
Thank you, Tim, for the introduction, and I want to thanks to all the participants today to join as a community program to educate patients about kidney disease prevention. We decided to talk today about kidneys and diabetes. What is the relationship? How the kidneys get affected with diabetes? And we're going to be going deeper and deeper on a different slides. At the end of the presentation, we're going to have some questions, and please feel free to keep your questions or maybe text your questions to Tim or the staff from the foundation, and then we're going to address those questions. Perhaps I'm going to start with a very basic question. What are the kidneys? And the kidneys basically is an organ that helps us to filter stuff. And you can say the kidney is like a colander, like a big colander that kind of keeps whatever we need and comes out, let it go, whatever we don't need. And the kidneys basically have this pipe that brings the blood in, the red pipe, and the red pipe brings all the blood to the kidney, and then whatever the blood is filtered, the clean blood comes back to the body on the blue pipe, and what we don't need goes back on the, you can see the pinkish pipe and goes to the bladder. So we have this organs, so we have two kidneys. They are located in the upper back. They are not in the front, they are in the upper back, and typically at the level of the last rib cages. And the kidneys, we have two kidneys. We're born with two kidneys regularly, and there are some occasions that we're born only with one kidney. And sometimes people donate kidneys. We call that living kidney donors. And it's okay, people can live with one kidney, provided there are no other medical issues later in life. Sometimes when people get a transplant, they can get three kidneys. Obviously two are not working, and only the transplant kidney is working. So the kidneys are, again, in the upper back. They are not in the lower back, and we have typically two kidneys. So we're going to be learning now what is the kidneys are made of. And as I said earlier, the kidney is an organ that filters. So it's a very complex filter. So as you may imagine, it has a lot of, you see there the red pipe that brings blood to the kidney, and then you see a little shaded sort of almost like a trapezoid or maybe a figure that kind of comes out with a gray arrow. That's how the signal is pointing out the units that filters the blood. These units are called the nephron, And that's where actually the whole of the process happened. The blood comes to the nephron, to these units, it gets processed. What we don't need, it goes back on the blue pipe, and what we need goes what we need goes in the blue pipe back into the body, and what we don't need goes to the on the pipe that goes from the kidney downwards to the bladder.
Dr.
So the
Barrantes,
kidney.
real quick, I'm sorry. Could you go ahead and share your screen so we can see the illustrations you're referring to?
Oh, I'm sorry
That's okay.
about that.
That's okay.
Okay.
Let's see.
How is it going?
There it is. Okay, very good.
Okay. So, so the kidneys, as I mentioned earlier, have this blue pipe that brings the blood to the kidney, and this pipe branch out in the smallest branches, and eventually we become tiny, like the one that you see here, with a little, like a wheel shape. It's called Bowman capsule, and it is called the glomeruli. That's where the filtration actually happens. We have 1 million of these units in each kidney, and when we have diabetes or high blood pressure, these are the units that actually are affected. So essentially, going back, the kidney is going to just maybe share the picture that I should have shared earlier. These are the kidney. It's like a big colander, very sophisticated colander. We have these two kidneys that are located in the upper back, and the kidney has this. What we don't need goes. You have this yellow pipe that brings the urine from the kidney to the bladder, which is down in the pelvis, in the lower part of the abdomen. So we have typically two kidneys, and now we're going to kind of learn what is the real picture of the kidney filtering unit, that we call the glomeruli. This is what actually looks in real life. The glomeruli, that's the unit that filters the blood in the kidney, and that's actually what it looks like. So when we have diabetes, these units, you see this round sort of ovoid shape with some stuff inside, like a little crushed paper sort of structure. That's called the glomeruli inside. That's where the filtration actually happens. And things like if this is like a diabetes can affect these specific units. We're going to be moving next one. We're going to just kind of summarize a little bit here what the kidneys do. So as I mentioned earlier, they do clean the blood. They are filtered, and they filter wastes. By doing that, they produce urine, and by doing that, they keep the fluid balance. What I mean by that is, whatever comes in, it should come out, and we should only keep some of this fluid or food that we have every day. If we have in excess, if the kidney is not able to eliminate the extra, then we start developing problems like a high blood pressure or maybe fluid retention. The kidney also helps to keep our blood pressure control. When the kidney is not working well, then you keep up, the blood pressure start getting higher and higher. And also vice versa, the high blood pressure can also damage the kidney, because remember, the kidney has this blood, is a bunch of blood vessels pretty much. If blood pressure if the pressure inside this blood vessel is pretty high, then the wall of this blood vessel are going to get affected. The kidneys also keeps a person's red blood cell count to be healthy through the production of a hormone. So the kidney makes a hormone that tells our bone marrow to make sure keeping our red blood cell count healthy. Keep our bones healthy. It can make some type of vitamin D. Keep our balance of the acids in our body in check. So when people have kidney problems, then we see an array of different symptoms that goes from no symptoms at all to symptoms like you feel fatigue, tired, you can concentrate, you have fluid retention, the blood pressure gets high, some minerals like the potassium or phosphorus start getting higher. So these sort of things can happen. So what do the doctors do to check on the kidneys? Typically, most primary care physicians, they run a test called chemistries, and fortunately the kidney blood test is in there. So it's called serum creatinine. And the serum creatinine will give you this marker called GFR, which is sort of the percentage of kidney function that the patient have. So the serum creatinine, along with the age, the gender, the race, and ethnicity, it calculates this GFR marker and tell us roughly what is the percentage of the kidney function. So we can also order a more sophisticated lab test called cysteine or cystatin. So that's kind of not very common, but we do order sometimes. We look at also the urine. In the urine, we're looking at the protein, we're looking for the sugar, we're looking blood, and there are different ways to look into that. We can use through a machine or through a microscope. We also look at the imaging of the kidney, how the kidney looks on an ultrasound, on a sonogram, or on a CAT scan. So those are clues that we kidney doctors use to make sense of things, and then make a decision whether the patient has a kidney disease, for how long has the patient have it, and then what can be done about it. So, as I mentioned earlier, we wanted to talk about diabetes because we feel that diabetes is one of the cornerstones of main causes of kidney failure in the U.S. and also almost worldwide. And I want just to start with a basic concept about diabetes. What exactly is diabetes? So if you go to the top part of this picture, you see a healthy, this is a piece of gut, and the yellow structure there is called a pancreas. The pancreas is the organ that makes an hormone called insulin. And that insulin allows the glucose, which is a byproduct of what we eat or produce every day as part of our metabolism. So this glucose to go inside the cells. So the glucose must go inside the cells, and the insulin allows that. The insulin tells a little door in the cell wall, in the membrane of the cell, in the outside of the cell. You know what? I need to have the glucose to go in. And then the receptor, which is the door, open up, and then the glucose goes in, and the blood sugars are stable in the body. So that's normal. That's healthy. In diabetes type 1, when the pancreas does not produce insulin, so there's a failure of the pancreas to make insulin, then the glucose is just hanging around outside, and there is no way to get into the cells. And then, so the patient has to get an insulin injection every day to allow the glucose to go inside the cell. If the patient doesn't get the injection of insulin, then the glucose gets higher and higher and gets sicker and sicker. And there are different types of diseases that happen when the glucose gets higher. People go into coma, people go into different states. Now, the diabetes type 1, which is the most common one, it happens typically at an older age, is associated with more like an overweight state. And in this type of diabetes, there is insulin. And actually, there's a lot of insulin. You know, if you compare the insulin is the little blue dots here, and blue round circles. You compare to the healthy one, you see much more insulin available. So you may ask, why is happening here? Why the insulin, that even there's a lot, is not allowing the glucose to go in? And what happens is there is a the cells fails to respond to the insulin properly. That's a problem. So there is a problem on the receptor. There's a problem on the sensitivity, we call it, of the tissues to this to the action of the insulin, and that creates a mechanism that we call insulin resistance. As we get bigger, as we get sort of more abdominal weight or fatty tissue, then we develop this hyperinsulinism, which in other words means high insulin and resistance to this glucose entry in the cells. So that's in a very simple terms, what is diabetes? So basically, no insulin or high or resistant to the action of the insulin, and you have a lot of high blood sugar, hanging around in your body. Now, high blood sugar is detrimental in our bodies if it's going for a long time. It's going to affect our eyes, our blood vessels, our hearts, our kidneys, our different organs that depends on blood supply. So you have there, is an example again, the high blood sugars is going to affect the muscles, it's going to affect the liver, gut. We talk about the pancreas making insulin, but there are a lot of resistance, and you have the fatty tissue causing a lot of these fatty acids. So how diabetes affected the kidney? Remember when I talked earlier, we have these units. I'm going to go back here, that unit. Tim, am I showing the right,
Yes.
the glomerular? Yeah.
Yeah.
So that unit, remember, this is the glomerular unit. So that's the unit that the diabetes is going to affect. And typically from this unit, we do not see any protein in the urine getting filtered through. So this unit is sealed to the protein elimination by the urine. In diabetes, we have a different phenomenon. So you see the healthy kidney on the left graphic, the urine going through. In the diabetic kidney, there is a protein leaking. There goes protein in the urine. So now we're going to go a little bit more in detail and see what happened. So this is a graphic on the left side. You see the normal glomeruli, which is the filtering unit. So the blood comes in one of these red pipes that you see going into this sort of nut shape. So the blood comes in, and then you have these cells here. You have this little red cells. You have this little cell like a triangle shape. So they kind of create what we call a barrier there. And then if you turn your attention on picture B, which is a diabetic kidney, you see a proliferation of different cells that is called the mesangial cells. They just start to become a lot of them. And then they start to, you see this green sort of membrane that goes like a ribbon and goes around those cells. That's kind of a thickening of the normal membrane they should be. And that's where the protein kind of starts going through. So most of the medication that we have available to prevent or decrease the damage is aimed at reducing the pressure in these units. And also is going and to reduce the inflammatory milieu, the inflammation happening in this unit. That's one of the medications are aiming towards. This is another picture that pretty much tells us the same thing that we just saw, but in a different way. On the left side, you see the glomeruli, which is the filter. Is you see the round thing, and then you see those components, the little round things going through this yellow pipe, going down the stream, and then some of them they're getting reabsorbed, they're getting outside from this yellow pipe, and then eventually some of it is going to go down to the end of the pipe. And you turn your attention on the right side, you see multiple of this square-shaped stuff, and some of the different round and different colors, which is pretty much symbolize the protein, the amount of protein that going, the excess of protein that is going through the glomeruli, and then eventually some of this gets reabsorbed. You see this cylinder shape that kind of reabsorbing some of this, but some of it doesn't get reabsorbed. And we see as a protein in the urine. In real life, what's happening is this: of a patient who has diabetic nephropathy, A is normal. You see the unit is completely okay, and or is still not showing abnormalities. And then you see B, C, D, E, and F. You see some yellow, some pinkish deposition material in that is kind of grouped together gradually as the disease progresses. So these are progression of the diabetic in the kidneys. You see, progressively people when they have diabetes, stage D or E, they're going to have a lot of protein in the urine. Patients who have diabetes in stage B or C, they will have a little bit of protein in the urine. Patient in type A, in picture A, will have maybe no protein in the urine. And the picture in F, the patient may not make even urine. I mean, the urine has collapsed already. There is no filtration happening, and we essentially lost that filtering unit. So, and that's when diabetes attacks the kidney. It attacks both kidneys at the same time, and the damage is happen in real time as the blood sugar is not controlled. As the time goes by, we see these illnesses when the blood sugar is not controlled. If the blood sugar is controlled, perhaps patients are going to be only in stage A or B, but if the blood sugar are not controlled, they progress towards C, D, E, and then F is almost kidney failure. This is a picture that shows us the natural history of diabetes in the kidney in type 1. So what does natural history mean? Natural history means how does the disease behave if we don't do anything about it, if we don't control well things. And you see in the bottom of the slide, you see 0, 5, 15, 25, and 30. These are the years of life of the individual. And in the upper part, you see 0, 50, 100, 150. That's the kidney function percentage. That's the GFR that we talked about earlier. So in the early time of diagnosis, like in the first year or so, the GFR goes higher because there's a hyperfiltration happening in the diabetes. And then as the years goes, at the 5 and 15 year, you see the red curve, which is the GFR curve, gradually shows the kidney function going down and down. As the patient goes to 15, 25, 30 years of diabetes type 1, the GFR goes all the way down until it reaches, almost 0, which is kidney failure. And as you see the GFR curve going down with age, you see the protein in the urine gradually going higher. The protein line is the blue line. You see at age 0, you have no protein or a small protein, and then gradually, age 15, you have perhaps 50, you have 300 milligrams of protein, and then gradually, as you reach 25, 30, you have a lot of protein, eliminating in the urine. So that's one of the important things that we need to keep in mind, that damage is constantly happening if the blood sugar is not well controlled, because it's a very dynamic process, a very, very, it doesn't give you any breaks, it doesn't give you any holidays, there are no weekends, for diabetes, it will keep damaging your body no matter what. So it's important to have some lifestyle changes that help you to kind of cope with these changes in the body. This is a natural history, similar idea of diabetes type 2. It's pretty much similar idea. You see here in the very bottom, you see nephron mass, which means kidney mass. And you see as the years go by, start from 100%, go to 50%, and then go to 0% gradually. The blue line is the GFR line. As the time goes by, the GFR gradually peaks initially because there's a hyperfiltration process, and then gradually start going down and down and down. And the same happens with the protein, and similarly for the protein in the urine. As the time goes by, the protein in the urine, which is the green line, you see gradually going higher and higher as the time goes by. So essentially, With time, what we see is a lot of protein in the urine, we see low GFR, and we see loss of the renal mass. What we see in reality on most patients, we see if you have a hyperglycemia, this is a picture, a table that shows us years. In the bottom part, you have years, 2, 5, 10, 20, or 30 years of disease. And then you see in the top part, if you have high blood sugar all these years since the diagnosis of diabetes, there is this, below this green line, green bar, you have all these medical terms, cellular injury, mesangial expansion, all this stuff. That's I said, these are the stuff that's happening in the kidney. These are all the technical terms that we use to name what's happening in the kidney. And then below you see what we see in the urine test. Microalbumin is when there's a little bit of protein, and macroalbumin is when you have a lot of protein. So as the time goes by, you see much more protein going. And the same for GFR. The GFR initially is high, and then gradually is normal, and then low, and progress towards ESRD as the blood pressure goes higher. Hypertension is one of the things that develop a few years into diabetic kidney disease. Anywhere between 5 to 10 years, people can develop high blood pressure and then develop this other complication. We're learning more and more that things like cardiovascular diseases or infections or death are very common in people who have diabetes kidney disease, and typically happens anywhere between 10 to 20 years of diagnosis. So it's important to pay attention to heart health, coronary artery disease, any cholesterol plaques, smoking, infections, urinary infections, bloodstream infections, and then later on we can see complications in the kidney, like kidney failure, as we talked earlier. I'm going to follow up. So the diabetes in the kidney doesn't, every patient who has diabetes do not develop diabetic kidney disease. It has to do, there are some risk factors that we use in medicine. And there are some risk factors that helps to start diabetes or to make people susceptible, and also other risk factors to help to progress the disease. For example, older age, men, Black, African American, Hispanics, Indian, Native Americans. So they are susceptible to have diabetic kidney disease because of genes. People who have family history of diabetic kidney disease, also they are susceptible. People with some ethnicities, like, for example, African Americans or Pacific Islander or Native American, they have a higher risk for progression of the disease. Things like a hyperglycemia that we talk about, it will affect initiation, susceptibility, and progression. Obesity, meaning overweight, affect all of them. Hypertension also affect the initiation, and the susceptibility, and also the progression. AKI stands for acute kidney injury, when the kidney suddenly have some problem because we took the wrong medication, because we got sick, we went and landed up in the hospital. So that we call acute kidney injury. When that happens, that also increases the risk of kidney disease. Toxins, like lead, for example, mercury can affect the kidneys. Smoking is a huge factor for susceptibility, increase the risk of kidney disease. Higher protein intake, and then and the same for increased progression. I think this is my last slide. I wanted to take some for you to take some home points. Diabetes does affect the kidney. It's real, and it won't tell you. It will tell you when things are very advanced. The majority of patients who have kidney disease do not have any symptoms. Uncontrolled diabetes greatly affects the kidneys. The longer that we have diabetes, the more likely the kidneys are going to get affected, especially if it has been uncontrolled. One of the ways to check how the kidneys are doing is by checking the creatinine, by checking the GFR. These are available in your blood test, in your regular chemistry blood test that the primary care runs. Checking the urine test once a year is a very way to check if the kidney is working healthy. And remember, there are some risk factors that we talk about, like obesity, high blood pressure, smoking, high protein diet, meaning eating a lot of meat, medication like ibuprofen, Motrin, or Aleve. Those medications also can affect the kidneys. So those are the basic things that I wanted to share with you. I'm sure you may have some questions. I'll be happy to answer some questions. And this is, as I said, this is the early stages of a program that we're going to develop as part of the Kidney Foundation Community Outreach Program. We're going to be talking next time in November on the 3rd about the medication for diabetes and kidney disease. And then we're going to be talking about in December, perhaps our lifestyle changes of kidney disease with diabetes. So there are series of talks that we're going to implement in this topic, and then gradually we're going to move to different topics. I appreciate for your time and your availability to be here, and I will stop for now.
Very good. Well, thank you, Dr. Barrantes. That's excellent information. And opportunity, if anyone has any questions, I did see that there was one or two of you who indicated that you might have some questions. So if you'd like to ask those now, just type them in the chat, and we'll have Dr. Barrantes address those. Or if it is more involved, we can answer that if you email the Kidney Foundation at info at nmkidney.org. We can get those to Dr. Barrantes and respond to them directly. So if there's any questions out there, please feel free to go ahead and type that in. We'll give just a couple more minutes here to do this. As Dr. Barrantes mentioned, we are going to be doing these kidney talks on a monthly basis. We are obviously the New Mexico Kidney Foundation, so our focus is the state of New Mexico and addressing the high-risk populations here in the state. But of course, this is open to anyone who is dealing with kidney issues, kidney disease, or knows someone do so. So please feel free to share these events as we go along. They will be happening the first Wednesday of each month at 5 o'clock Mountain Time. And we'll be posting them as soon as possible, as soon as we know the topic and the presenters on our Facebook page. So go ahead and like and follow us there, and you'll be able to see the next one coming up. So Dr. Barrantes, we do have a question. Okay, so it's more of a comment here. The question really, okay, so this individual notes some of the conditions she's experienced. Says that nobody in my family on either side had diabetes, only herself. We don't know why. I did have Hodgkin's lymphoma over 25 years ago, heavy radiation, which damaged her heart, and now I have a mechanical valve, and I've now had many CT scans with iodine. Could that have hurt my kidneys? So I think perhaps both, specifically the iodine, but perhaps also the radiation as well.
That's an excellent question. Unfortunately, I'm not sure what type of radiation did you receive. If you received total body radiation, most likely it may have caused affect the kidney. Usually the radiation affects the blood vessels in the kidney, causing high blood pressure. And the effect is more acute, so it happens regularly after the radiation. And then later on in life, there is some fibrosis that can happen on this blood vessels area. In terms of What was the second part of the question you said?
Well,
What was the radiation?
CT scans and with
Yeah, the
iodine, and could that
contrast.
have caused problems?
Yeah, the contrast do affect the kidney, especially when they are taken in acute setting. So meaning when people are sick in the ER, people are in the hospital, they have other issues going on, and then they get a lot of dye. That dye is going to have higher risk of affecting the kidney. When the creatinine level is below 1.2, 1.3, or the GFR is more than 60, and the contrast effect is much less in the kidney. So typically, kidney can withstand that, but it's very important to address the patient to hydrate themselves well before those CAT scans are done, or maybe get some fluids through the veins, yes, to make sure the kidneys are able to flush out the dye faster.
Very good. We do have another question with regards to chronic kidney disease, and the question is, does CKD cause nausea and fatigue?
That's a good question. I would say up to CKD 4, which is GFR above 20%, people don't have much of the symptoms typically. They feel fairly okay. Most of the nausea and the decreased appetite comes when the GFR drops below 15, which is after CKD stage 5. As the GFR drops below 20, below 15, you're going to see more of the nausea or issue with the GI tract.
Very good. Okay. I have another question related to dialysis. Excuse me. So I now do PD dialysis, and I'm finding I feel better, but my sugar is high. So why do we recommend PD for a diabetic? My sugar is higher than it's ever has been. I'm thinking about changing that.
You raise a great point. Unfortunately, science hasn't gone a lot yet. We use these high glucose solutions to put in the abdomen to create, it's called osmosis, to create a physical phenomenon to pull all the toxins from the body to the abdominal cavity, then they can be eliminated. Yes, the high blood sugars in those solutions raises your blood sugars. What I typically is discussed is the patient has to increase the doses of anti-diabetic medication, meaning insulin. Or sometimes you can discuss with your nephrologist the use of medication or use a solution called icodextrin. Icodextrin is a polymer that is not glucose-based, and the icodextrin can be used in people who have a tough time controlling the blood sugars while getting peritoneal dialysis. It's available. You can ask your nephrologist or the dialysis unit whether the icodextrin is available. It's spelled ICODEXTRIN.
Very good. And related to that, would that also affect blood pressure, increasing it, hypertension?
One more time.
So
The blood pressure.
the PD dialysis, would that also have an effect on increasing blood pressure, causing hypertension?
I don't think so. I think the dialysis, the peritoneal dialysis, is done to remove the extra fluids and the sodium from the body. So perhaps when the prescription need to be readjusted over the dialysis, when the prescription perhaps under prescription, people are going to have more likely more high blood pressure because the salt and the water is being retained in the body. So perhaps needs one more cycle, perhaps needs more volume on the peritoneal dialysis, or perhaps need to take more diuretics or some blood pressure medication. But the peritoneal dialysis on itself does not cause high blood pressure.
Very good. Well, those are the questions we've had so far. Again, I want to thank everyone who joined us for this live event. We hope to see you again next month. And of course, continue to follow our page. We'll be posting more activities as we go along. as well as go and look at our webpage at www.nmkidney.org. We have a lot of information and opportunities, actions you can take with regards to registering for donations of organs, to be active in regards to doing what we call the 7Ds for your kidneys. Also volunteering, and of course always welcome any opportunities to have your financial support with regards to addressing the needs of those who have kidney disease and helping them with getting the transplants that they need, as well as really on the front end, really making an effort in preventing kidney disease. Our objective is to reduce kidney disease in New Mexico, and the key way of doing that is to keep it from happening to begin with. So join us again, and again, thank you, and we'll see you in a month. Thank you, Dr. Barrantes.
Thank you very much. Bye-bye.
Bye-bye.